It's my pleasure to soon start this plenary this morning. My name is Nino Künzli. I'm the Dean of the Swiss School of Public Health, and you all know this session this morning is on a very important topic that stands with us since more than 2 years. So the long and the short of long COVID. I'm very happy we can run this plenary this morning, and I'm very glad that, in fact, our president of the Swiss School of Public Health Foundation, Milo Puhan, will be with us and talk as a scientist and not as a president of the Swiss School today. I just want to let you know the Swiss School of Public Health, which is this virtual faculty of public health spread across 12 universities in Switzerland. Of course, we were also very much stressed by the pandemic. That's true for us. We did not predict it either. We did not wait on it, and we had to react on it. And for us, like for many public health communities, it was also an incredible booster of understanding how important our science is and making contributions to this very, very major stress for all societies all around the world. And that was also true for Switzerland. And I'm very glad that the Swiss School could make actually two most important contributions as a Swiss School of Public Health. And I'm not saying, of course, our faculty spread across 12 universities, they did a lot on their own, they did a lot of research, but we as the Swiss School, we had two major issues that we were launching and running since the pandemic. And the first one is the Corona Immunitas. So when Professor Milo will speak very soon to you, you will see on all the slides on the top this Corona Immunitas. And what that is a really, really amazing initiative of Professor Puhan together with the whole network. We were able to launch within 1 month a very, very serious, very large survey to monitor the development of the immunity in the Swiss population, with more than 50,000 people participating in more than 40 projects. And this was only possible because we, as the Swiss School of Public Health, existed, because to implement and start and launch such large projects, programs, you can only do with an existing structure. So we're very, very happy and glad actually that Milo made this initiative together with all our colleagues around Switzerland. And the other piece, and this is more related also to what Professor Puhan will show now, the Swiss School received a mandate from the Federal Office of Public Health. We proposed them that they can access our expertise that is spread across the 250 faculty members in all these universities. And one way to give them access to our expertise is this mandate where the Federal Office of Public Health formulates questions, research issues where they need assistance in having the experts reviewing the literature. So we have some 10 projects running on different questions of the Federal Office where our community, our network experts spread all over Switzerland would provide regular reports on where the literature stands. And as you know, this literature is exploding. Fortunately, it is exploding. We learn a lot. And one of those projects actually has a focus on long COVID. And I'm very glad that the Institute of Professor Milo Puhan is actually working on that. And this is also the topic that Milo will now address with you. Long COVID, the short and the long. Milo, I'm very proud that you are here, and I'm looking forward to learn more because I never time to read the literature myself anymore. Thank you. The floor is yours. Thank you. Thank you, Nino, for the introduction. Very glad to be here. Traveled to Ticino, my second home here in Switzerland. Yeah, I will talk about long COVID and how frequent it is, what the burden of disease is. But before that, I would really like also to take a little bit of a historical perspective, because I think a lot of the discussions that we hear now, the uncertainties that we have or had about long COVID, have been around for a long time. And what is interesting when you look back a little bit, you see that post-viral syndrome, and long COVID is nothing else than a post-viral syndrome, has been around for a long time.
It was just difficult to capture these syndromes because there was never really a systematic investigation into it. And I will explain to you why this was the case. But I will also then show you how unique the opportunity now is to learn about post-viral syndromes and also like diseases like chronic fatigue syndrome. And when we look back to the Russian flu, for example, which by the way, it's actually quite an interesting story. It was probably not influenza. It's always called the Russian flu, but there is quite a discussion what actually caused it. There is also the hypothesis, and I think evidence that it was rather a coronavirus than influenza. Of course, at that time, the virus were really not really well known or established, only a little later. But there was something happening in the population that affected many people. And later on, after this flu, 1 to 3 years, there were many reports already from people complaining about fatigue, about anxiety, about not having energy to do their daily duties and so on. So exactly the same symptoms that we now see with long COVID have been reported more than 100 years ago after the Russian flu. And again, at that time, there was just no chance to test for a virus. I mean, the viruses were even not really known by them. So it was really a time where it was very fuzzy what this pandemic or this plague was what was about. But still, the discussions whether these symptoms afterwards could be attributed to this pandemic before, there was a lot of discussion whether this was really due to that or due to some other developments. Like today, I mean, like we still have the discussion in long COVID that people say, oh, this is due to some other, this is just due to the pandemic, to the stress people feel, or it only affects those who have a preconditioned psychiatric condition. And so all the same discussions were around back then already. Also a little bit of a fight between those who see this more as a psychological psychiatric disease and more those who see it entirely as a somatic disease. So the same discussions were going on already then. And also for the time after the Spanish flu, and we have two experts in the audience from the Spanish flu, the same reports happened. So also reports about not systematic reports. We don't know how many people were affected and how severely, but exactly the same symptoms were reported. And we also have some evidence about the potential social and economic consequences of such a post-viral syndrome. And I just show you one example. It's quite a famous example from the East Africa, so the famine of corns. It's one of the greatest famines that happened in Eastern Africa, which was really very much affected also by the Spanish flu. It was the time of the World War I, where first the British traveled along the railways, then at first the Germans, then the British, and of course they brought the pandemic also to today's Tanzania and Malawi and so on. And it's estimated that about more than 50% of the population were infected back then. But what happened afterwards is that many, in particular also younger people complained again about fatigue, about feeling no energy, feeling depressed, and some of this was then attributed to the loss of the workforce in agriculture. So there was too little workforce in agriculture, and this is what caused, together maybe with the war, caused this famine. So you see, there can be, if you have a substantial loss of the workforce, of course, there can be quite dramatic social and economic consequences. And this is just one of the examples. So, but when we also look further back, oh, this doesn't show, too bad. It's actually a picture from even earlier, the 19th century. Too bad that it doesn't show because it's a really nice picture. It shows, again, a very similar symptoms that were around, that were around. And but then it was not attributed to any disease, but it was thought to be just the overburdening from industrialization. It was also called Americanitis, you know, the consequences of just being overwhelmed by industrialization, But again, you saw exactly the same kind of symptoms that were reported. I don't know if there was an epidemic or pandemic just before that. It may have been a mix between things. But again, it was the same discussion about figuring out how many of these symptoms that occur can be attributed to an infection people went through before or to some other issues. And we'll come back to that when we also try to estimate the prevalence and the symptom burden that we see today in long COVID. So this is one side where you see the post-viral syndrome emerging. The other is, of course, in clinical practice, this is very well known for a long time as well, that people after an infection, for example, Epstein-Barr virus or after influenza, they suffer from certain symptoms. One prominent symptoms, by the way, that is also present in some people with long COVID is this post-exertional malaise. This is really something really nasty. So whenever they do a little more exercise, they have an exacerbation, acute worsening of the symptoms, and then have to really slow down again. So this post-exertional malaise is also one of these symptoms. And you also see symptoms that go well beyond the brain, the central nervous system. So you see also gastrointestinal problems, muscle or musculoskeletal problems. And I will show you a little bit what are the theories behind it or the pathophysiology. Let's just see why these post-viral symptoms can basically affect the entire body. And of course, well known is also chronic fatigue syndrome, whose prevalence is estimated in the US at least to be around 1% of the population. I think there is a lot of uncertainty about these estimates, but it is something that is very well known. People who suffer for a longer time under these symptoms like that you see here again, and which is really cause a lot of also limitations in daily life, in the work, in social life, family life, and so on. So what I just wanted to tell you here is that really these post-viral symptoms are not new at all. And I'm also asked many times the question now, what is then the difference between the post-viral syndrome after SARS-CoV-2, like long COVID, and after influenza or Epstein-Barr virus? And always say, we don't know. We just don't know because none of these viruses could be studied in such a systematic way as we now do it for SARS-CoV-2. And the simple reason for that is that we have such widespread testing. We have testing across the population from asymptomatic to severely affected. So through the whole testing regimens that we have, we capture many, many, many more than we ever did before for a virus. Usually before it was just suspicion that a virus may be there and that there was some testing, but there was never really a systematic approach to population-wide testing. And so we really do not know what the prevalence, the distribution of severities and so on of the post-viral syndrome after influenza and Epstein-Barr virus are. Okay, but let's turn now to long COVID. Just the symptoms that are reported are really numerous. More than 100 symptoms have been reported. We also summarized that a bit in one of these reports Nino Künzli referred to. So that's our living review of the Swiss School of Public Health for the Federal Office of Public Health. So you see here that it really affects the entire body, the brain, with symptoms I already referred to, but also the heart, the lungs, the gastrointestinal symptoms, and also quite a few people complain about problems with the skin or with the hairs. So it's really you have a wide set of symptoms that can occur. But to make it a little simpler, the main symptom clusters are around this fatigue, are around cognitive problems, the so-called brain fog, problems concentrating, and respiratory problems. These are the three main symptom clusters that exist. So if you want to have it a little clarified, not deal with these hundreds of different symptoms, I think it's easier to refer always to these three symptom clusters. Now, what is really amazing is how many studies were done very immediately during the pandemic. And this is a very confusing graph that was shown in a review. We slightly adapted that for our review. What you see here is a number of different studies that was until about a good year ago that try to estimate the prevalence of long COVID in the populations they assessed. Here you see here days of infection on the x-axis and on the y-axis prevalence. You see prevalence estimates basically go from whatever 5% to 95%. So this was very confusing in the beginning, very confusing to getting your head around what this really means. I draw a dotted line at 3 months because this is where we now define long COVID to be present. But you see, there were reasons, and we figured out, I guess, quite well also the reasons why these prevalence estimates are so different. More than 90% of the studies enrolled patients from a convenience sample, from some sample in a hospital. So all who were hospitalized, they followed them up, and after 3 or 4 or 5 months, or even after 4 weeks, they had like 60%, 50%, 70% who have not recovered from the infection. So you have most studies had very selected persons in their study. You also had huge diversity in terms of severity of infection. Again, most on the severe and very severe side. Very few studies on the population bias and outpatient side. So happy to say that actually 2 of the few studies in this respect come from Switzerland. Then, of course, very different definitions back then on this post-COVID-19 condition, how it's also called, and now officially about WHO. So some just counted any symptoms that occurred and said, yeah, this is long COVID, and others said, no, we need a set of symptoms or some other criteria. Then time of infection, fortunately, prognosis is not super good, but symptoms get better over time, so it depends a lot when you do actually assess that. And then there's different risk factors for it. I will come back to that. Depending on how they are distributed, you get different estimates. Then, of course, how you assess the symptoms, the symptom burden. And something I think that is quite interesting, I found, is the focus of a study. If you focus, you have a study and you invite participants to join a study on long COVID, you have a lot of self-selection into those studies. So all these studies that set it up from the beginning that we do a study on long COVID have much higher numbers in terms of specific symptoms or burden from these symptoms, as opposed to a study where you may study something else or different, you follow different aims, where long COVID is just one of them. So this can really make quite a big difference how patients select themselves into a study. And finally, of course, the issue of the control group. I mentioned before that all the symptoms that you heard are not very specific, and they happen in the population, like pain, musculoskeletal, arthralgias, and depression. All of that is very prevalent in the population, so you need to account for that as well. When we tried to narrow it down, this is the definition, by the way, a WHO that came out about a little less than a year ago. This is the clinical, so-called clinical case definition, is the consensus definition. There's nothing else you can do but sit together and try to come up with a reasonable definition. So you see here, it's something after a confirmed infection or likely infection. This is very important. The likely infection is very important because you have many people who do not have confirmation of the infection. When we look back over the last 2 or 3 months, most people didn't test, although they got an infection with the Omicron variant. And that's also very important, tricky for the insurance business, by the way. Those who try to get support from an insurance, this is always a tricky point, whether you can prove that you had an infection or not. Then again, needs to be the infection needs to be back 3 months. No other diagnosis that may explain the symptoms, and then a set of symptoms. You see again these 3 clusters that are also emphasized by WHO. And very importantly, the symptoms can behave very differently over time. They can be there all the time, fluctuate, really come back. And you see all kinds of clinical presentations of that. And I think this helps a little bit with prevalence studies, because at least we do not focus much on the studies that were done in those who are followed up after 4 weeks after infection, which I think really doesn't make sense to talk about long COVID 4 weeks after an infection. Okay, but when we look then at the literature and just focus on population-based estimates, we did that in our review with studies we thought would be reasonably well conducted with or without a control group, but we arrived approximately at an estimate that about 20% of people do not feel fully recovered, still have symptoms at 3 months or more. You will see that most of them, fortunately, are mildly affected, but still, they feel the consequence of that. It was quite nice to see that almost at the same time when we published the update of the report, the CDC came up with a similar review, and they arrived exactly at the same number, that 1 out of 5 persons with a confirmed infection do have problems a month after the infection. And then risk factors, this was quite unclear for a while. What are the risk factors? What is very clear is pre-existing conditions are a substantial risk factor. Being a cardiorespiratory problems, being a psychiatric diagnosis. I guess the reason for that is just you have a symptom burden and you just do not tolerate much more what is then coming from this post-viral syndrome. So pre-existing condition is an important one. About 2/3 of people affected are female. Severe infections increase the risk substantially. Although in absolute terms, this is always very important to remember. This long COVID is not just an issue of those after a severe infection. More than 90%, when you look in terms of absolute numbers, more than 90% had a mild or even asymptomatic infection. This is important to emphasize. And again, not being vaccinated is a risk factor as it clearly emerges, I think, now. What is also important to realize is that sometimes you hear, oh, I don't see any patients in the clinic who come with that, or you have a lot of selection mechanisms, whether you're in the healthcare setting, in the professional settings, to estimate how frequent it is. And this is because the manifestations can really show up either in the healthcare system, but actually quite few seek the attention of a healthcare professional, but they show up in professional life very much, and also in social and family life. The numbers, again, are very different across countries. I think it also depends on the safety net you have for people. Countries with a not so good safety net, like the US, I'm sorry to say, but there people drop out of the job much quicker than here, where there is people, it's accepted that people slow down for the time where they have not recovered yet. So the numbers in terms of unemployment and things like that are very different, because again, the safety net is very different across countries. So just a few words, how does this happen, this post-viral syndrome? Many theories or findings so far, but no consistent picture. And probably the truth is that several mechanisms together cause this post-viral syndrome. So one of them is that there is some systemic inflammation going on, some autoimmune mechanisms that is not very well understood, but just something that triggers the immune system on a constant base and causes to this imbalance in the immune system and causes this constant inflammation. This is one thing. The other thing, you clearly see that the vascular system is affected. Endothelium is damaged, erythrocytes are damaged, thrombocytes are damaged, and then you just have a poor microcirculation in the organs. And this may also explain why it really can affect all the organs. So you see there is a number of mechanisms that have been proposed. There's a lot of research at the moment going into that. I don't think that one pathway will emerge as the dominant one. I guess it will be a combination. What is not even mentioned here is this post-intensive care unit syndrome. You know, those who were really severely sick, they have consequences of being ventilated, mechanically ventilated, and all of that. So this doesn't even enter the equation here. But you see, there is many factors that can actually contribute to this long-term sequelae after the infection. Now, this is actually also, it is an exciting situation to finally study a post-viral syndrome more systematically. Again, because we had this widespread testing in the population. And what you would like to do, ideally, it's really interesting also from a methodological perspective how to tackle that, but what you like to have is a population-based study to really have a view on the entire population and not just the clinical one. Ideally, you follow these people up to also learn about the prognosis of that. I think ideally you recruit invite participants from all those who were infected in the population, or at least tested positive. And again, it should cover all kinds of severities of infection, from asymptomatic to very severe infections.
And you should know the date of infection because, again, the symptoms get better over time. So you need the exact starting point. Otherwise, you cannot interpret and the finding that you get out of it. What is also quite important, of course, is that you capture all the risk factors, again, to interpret your prevalence or whatever estimates you get. And you need to have a smart way of getting the information from the participants. There is no biomarker that tell you this person has long COVID, it's more or less severe. There's just not much out there yet, although there's a lot of research going on, but most of information, and rightly so, comes from the people affected by it. But you need to have a smart strategy how to ask people to figure out what is really due to the infection, what might be due to other reasons. And again, I mentioned the focus of the study. I think ideally you do it alongside other aims in a study to control a little bit for the self-selection mechanism, and ideally you have a control group as well, people who have not been infected. And it's actually quite fortunate that we embarked on this more than 2 years ago. So we had an infectious disease doctor on the team, epidemiologist, and when we designed this cohort study in Zurich, we were focused really on the immune response from day of infection throughout. We are still doing it until end of 2023. We see how the immunity develops over time now with booster vaccines or with infections and so on. So this was the primary focus. We also focus on the experience of isolation in the beginning. So many aspects, but this infectious disease specialist, Talabalu, said, let's also focus on the long-term sequelae of that. And so we incorporated that very early on questions on persistent symptoms. And this is how it worked. It was actually, since we are not that far with digitalization in Switzerland, it was very painful to set this study up. So we did it within the health director of the canton of Zurich, because this is where the mandatory reporting of infection goes. But it was still at the time where it was transmitted by fax machines. The numbers were put together in some Excel sheets, so it was extremely painful to have all people who got reported, then apply the eligibility criteria, and from those randomly select invite participants. It was a very painful process, but we somehow succeeded to do it. It got better over time and enrolled 1,500 participants, where still more than 90% are still part of the study. So it's really amazing. The adherence of people to the studies in the Corona times is really, I think, very amazing. And this is, you see the starting point of the infection, because we had the exact date of the infection, and then we follow them up with questionnaires, and we take blood in regular intervals, again, to address all these different study questions. And this type of study turned out to be really useful to get insights into the prevalence of long COVID, into prognosis, but also how severely people are affected by it. And I just want to say something about these patient-reported outcomes, because this is really key. What we learned is that you need a combination of questions that address long COVID from different angles. So we have a combination of a recovery question, of symptom assessment, and health status. What does it mean? So symptom question, of course, you ask for specific symptoms if they're present or not. So you may go over all these 100 symptoms that have been reported, ask them if they're present or not after 4 weeks, 3 months, 6 months, 12 months, and so on. Or use also validated questionnaires to assess more complex symptoms like fatigue or respiratory problems and so on. And of course, we do that. The problem with that is you cannot link those questions to the infection. It's very hard unless you change all these questions and relate it to the infection. But as the instruments are per se, they're not linked to the infection. And often it's very difficult to say whether these people are doing fine or not. They may have, in a certain domain, may have substantial symptoms, but overall, they do actually quite fine. And this is for these two reasons, we added 2 additional types of questions, so-called recovery questions, and these are very useful. So you simply ask people in regular intervals if they feel recovered from the infections, or if they still have persistent problems. And we ask that really at every assessment. This is one thing that proved to be very useful. And the other one is this health status. You may know the EQ5D, so that's probably the most common. EuroQual is probably the most commonly used instrument also in health economic assessment, where you get an estimate of the health status of person. And we use in particular the so-called feeling thermometer. It's a visual analog scale where you simply ask people how they do today or in the last
7 days, depending which version you take. And this is a super useful question. I used it many times in different disease areas, and it proves to be a very useful indicator for overall health. So in these three types of questioning combination give you a very good idea, a very good characterization of people who are affected by long COVID. Now, and of course, we have a biobank to look into biomarkers once if they emerge, but that's a difficult task. Anyway, I will now show you some results because I think it's quite interesting to see what you get out of this study setup. So after 6 months, when we looked at it first, we saw that still 24 out of 100 were infected. So these are kind of natural frequencies. 24 out of 100 still didn't feel recovered, had symptoms. And so this is the recovery question combined with the symptom questions. And we have the severity. We looked at the severity and how impaired the health status is. And for this, we use this EQ5D. And so this gives you an idea about how the severity is distributed. Fortunately, most people are relatively mildly affected. They feel it, but it doesn't impact too much on their daily life. Then there was, at that point, 6 months, there was like 5 out of 100 who were moderately affected. We had some criteria how to define that. And these are people who have to reduce workloads, have to reduce their social life and so on. And then we have 3 out of 100 at that time. This was still after infection with the wild type, the original version of the virus, who were severely affected. They really had to stay home in the bed most of the time. And this is now how we have now 2 years of follow-up. This is how it develops over time. So it definitely gets better, but there is still a substantial proportion, even after 2 years, who do not feel recovered, who still have these questions, these symptoms. So the prognosis is there. I mean, people do recover, but it's not super fast, and some really have persistently problems with this post-viral syndrome. Another, I think, interesting look is to look what is really likely due to the post-viral syndrome and what is explained just by other health conditions that are around. And this is the excess in symptoms that you see, smell and taste alterations. Of course, this is something you do not expect much in the population. We had a control group from Corona Immunitas with non-infected people, and you see there, this is on the top, you see there then close to 1 or 2%, like have these symptoms, but far more after still 6 months after the infection. And the excess you see then on the right hand side, you see is about it's about 10%. And then you see going down which symptoms really are more prevalent, can be attributed to these post-viral symptoms rather than being around all the time. So, for example, with the musculoskeletal problems, we do not see an excess. This does not exclude that certain participants, of course, have pain in the muscles, in the joints, and so on after the infection. But on a population base, we do not see much of the signals for these particular symptoms. But you do a signal for this post-exertional malaise, for the concentration difficulties, for the fatigue, for the respiratory problem. You see a clear excess of these symptoms even after controlling for the prevalence of these symptoms in the general population. And what is also interesting to see is how the symptoms develop or traject over time. Focus first on the right-hand side, because these are the recovered, and it shows you also a little bit how well this recovery question works. Because you see at the beginning, they had some value at the time of infection, and these are symptoms that do not come with the infection necessarily, except of respiratory. And you see an increase during the infection, but then it went down, and at the end, or even after 6 months, they are at the baseline or even below. And this is why they feel themselves recovered. And these are independent questions, but you see how well this recovery question actually works. On the other side, the non-recovered, they are also after 12 months, 24 months, still higher than they were at the beginning, so they do not feel recovered. And what is also interesting, you see again the pre-existing conditions. They had from the beginning, they had a higher symptom burden, and this is really one of the risk factors that you cannot compensate the problems that come after the infection. So I think that the cohort study just gives you a very powerful tool to look into all of that and get a much better understanding of this post-viral syndrome that I think that we ever had before. And of course, new questions come up. There's also a beauty of a cohort study. You are not stuck to the initial questions, but you can ask additional questions. Of course, one is, what is the additional effect? What is the risk lowering effect of vaccines? and what is the effect of different variants. Vaccines, you may remember the vaccination campaigns, I think in most countries, also for the boosters, did not include much long COVID. Why was that? That was a hesitation because the evidence was just not there. Let's say last fall, last winter, was just not there to confidently say that the vaccination reduces the risk of long COVID. I think it was good for the authorities to stay on the more cautious side when you don't have the evidence. But over the last few months, there were a number of papers coming out, and they show quite a consistent preventive effect of the vaccinations, in particular the mRNA vaccines. So quite a consistent effect there. I think we can now be more confident, or be quite confident there that there is a preventive effect. I'm curious to see whether some authorities pick this up and also include it into the booster, let's say, vaccination campaigns as an argument for getting a booster. But on the other side, there was also the question whether people who do have long COVID, whether they benefit from a vaccination, and there you just don't see, we call it the therapeutic effect, that you don't see much of the effect, very inconsistent results across studies. Okay, this is the effect of the vaccination. So we clearly see there is some preventive effect. And on the other side, what do the variants do? And there's very little evidence out there yet. And one reason for that is also you need studies over 2 years or more to cover all the variants, and not many studies like that exist. But this is one study from England that looked at mostly vaccinated people and showed that with Omicron, long COVID really is cut about in half or even more compared to the period with Delta infection. So this is an indication that Omicron is less of a risk for long COVID. Still, this is in relative terms. By the way, we have huge numbers of infections in absolute terms. It still means that many people get long COVID symptoms. There is also important implications, for example, for treatment trials. There are treatment trials finally underway. What is very important, what we learned also from the sports studies, that you need to find a smart way of defining the eligibility criteria for that. And for example, but what we think is very useful to look at these patient-reported outcomes, focus on those with a symptom burden, those who have not recovered, because otherwise you run the risk of including relatively healthy people where you have no chance of detecting an effect. So I think these patient-reported outcomes give you, in combination again, give you a good tool to define study populations. Then again, combination of these outcomes, and what is super useful, since you have this recovery and you have data from observational study, you can estimate what is likely to happen in the control group patients. And this is very important to interpret the finding when you then have people who got a treatment, and also, of course, to calculate sample size requirements and so on. So I think we can learn a lot from these observational studies to inform the treatment trials. And the other thing, I think the practice outside of the UK, I say a little provocatively, healthcare is a little bit left alone how to deal with this. GPs also, and so on, and insurance medicine. So we made an effort together with colleagues from the University of Basel and the Bern School of Applied Sciences, Bern University of Applied Sciences, to develop an assessment tool, a systematic assessment tool for clinical practice for GPs or any health professionals that captures the most important aspects. So the idea of this is that you capture some baseline demographic characteristics, occupational data, functional status. So these are all data you capture relatively quickly, but then have these validated instruments, the recovery question, validated instruments to get better insights into the symptoms. And the idea of that is that it's now, hopefully it's going to be implemented, is that people can fill this out before they come to the practice. So all done before. This is a model that is well known in healthcare to really be very useful for healthcare if you have such systematic information available. And then the healthcare professional basically can deal with the summaries that are automatically projected to see in which areas the people have problems, where they may need some support or treatment, and how this develops over time. So you see, we have hopefully this happens, but the idea is to really inform also practice, to give them useful tools to capture these complicated post-viral syndromes a little better. So these are just some implications of the research that comes out. So finally, I think what I found just exciting, and also when I looked a little bit into the history of these post-viral syndromes, it's really the opportunity now to study post-viral syndromes in a systematic way. And I don't know if it will ever happen again. Antoine may know how systematically the population will ever be tested again for viruses. We don't know. But with SARS-CoV-2, I think we had a unique situation that we had this almost population-wide testing, which then gives you an excellent basis for really doing true population-based studies on SARS-CoV-2 and on long COVID now in this case in particular. Good. With this, I close and very happy to discuss some questions.